Hello, everybody. My name is Aoife Kerwin. I am the Information Officer with MS Ireland, and we are absolutely delighted to be joined by Dr. Hugh Kearney this evening to discuss the topic of relapses in MS. Dr. Kearney completed a PhD in University College London investigating the use of spinal cord MRI in MS and the association with disability. He completed his clinical training in neurology in Ireland, including a 2-year postdoctoral fellowship in genomics with Future Neuro. And he currently works as a consultant neurologist in St. James's Hospital and is leading the newly established MS unit. He's also part of the academic unit of neurology in Trinity College Dublin and is developing a research group focused on transitional research in multiple sclerosis, including the development of diagnostic biomarkers. So the format that we're going to take this evening is we are going to hand over to Dr. Kearney in just a minute. He's going to talk us through his presentation and the topic. And if any of you have questions, we would ask you to submit them through the chat function or through the Q&A. So myself and my colleague Alison will be keeping an eye on that. And then towards the end of the session, we will ask as many questions as we can to Dr. Kearney. So we're hoping to keep it within the hour. So we hope to finish up about 8 o'clock. So again, if you have any questions, we'd ask you to pop them into the chat box. Just a reminder, this session is being recorded and it will be made available on the MS Ireland website in the coming days. And with that, I'm going to hand you over to Dr. Kearney.
Thanks very much. So I'm just going to share my screen first of all. Right.
Yeah, that's perfect.
Okay, so thanks very much, Aoife, for the introduction and for the invitation to talk this evening. So as Aoife said, Hugh Kearney is my name. I'm a neurologist in St. James's, and I'm also involved in research work with Trinity, looking at different components of MS. So what I've been asked to talk about this evening is about relapses in MS. So I suppose this is just kind of an overview of the talk. What is a relapse? What happens? How do you know? And then we'll go through it. So first of all, what is a relapse? So there are common symptoms of MS, and these can be presenting symptoms for many people, but they can also be symptoms that people can experience during a relapse. So common things would be things like an optic neuritis, where you might get pain behind the eye and difficulty with vision. A lot of people would describe it as a sensation where they might have a feeling like there's Vaseline on the lens of their camera or something like that. You can get a change in sensation where you might get numbness on an arm or a leg or up both legs. You can get what's called a motor relapse, and this is where there's a weakness in a part of the body. There are more recently what have been described as cognitive relapses, and this is where thinking or memory or cognition more generally can be affected. So everybody has a certain baseline, and if there's a really sharp drop in that in a short period of time, we think of that as a relapse. But it's possible to get a mixture of a few of these. So these are kind of the four most common, but you could have a change in sensation, but equally some weakness, and then we'd say it's a mixed motor and sensory relapse. There is a kind of a strict definition of what a relapse is, and I have it on the screen there. So it's kind of, the main thing really is that it lasts more than 24 hours. So it's not a temporary thing, because for people who do or don't have MS, it's perfectly possible to get neurological symptoms that come and go. So for example, if you sleep in an awkward position and you wake up with your hand feeling pins and needles, or if you whack your elbow on the corner of a chair or something like that and you've tingling, it's obviously very brief and there's a known cause. You know, even in the context of MS, that wouldn't be a cause for concern. But if it's a symptom that doesn't have a known cause, it lasts for more than 24 hours, and there's no obvious trigger in terms of a fever or anything else. And as long as it's more than 30 days from the last attack of MS, it tends to be the case that it's unusual to get more than one relapse within a month. So they're kind of the different components of the definition. So in a relapse, the symptoms, they usually appear suddenly, or else they kind of worsen over a period of time. And it's hard to put a timeline on any of this because it's quite individual, and it depends on the person. It depends on the sort of level of awareness of their own body, and it depends on the how active the person's MS is. And when you say quickly, some people would experience things coming on over a period of hours. And for a first presentation of MS, sometimes this can cause confusion. It's not uncommon. We'd hear the story that somebody has a very sudden first presentation, and presenting into hospital, it can even be thought they've had a stroke. The other thing is, for other people, it can take place over days. So they might begin with sort of tingling in their feet, maybe a day later up to their knees. And then over the period of 2, 3, 4 days, the tingling goes up to their tummy, up to their belly button. And then they've a sort of more awareness that there's really something definitely going on. I think one thing that can be a source of confusion is, what do you call it? So I suppose the medical term is a relapse, but different people would have, sorry, beg your pardon, would have different names for what it is that's happening. So some people would say they're having an attack of their MS, an episode, a flare-up, or an exacerbation. It doesn't really matter. They're all just different names. And I think the important thing is to be able to identify when it is happening to yourself, so that you can discuss it with your treating team. In relapsing remitting MS, which is the most common type, it's possible to go months or even years without a relapse. This has kind of changed a lot with the use of disease-modifying drugs. So some people initially might sort of be nervous, oh, this is going to happen in the next day or the next week. But the much more common type of scenario is that it might be a year or even 2 years later after a first presentation, if all is going well with the drug. And the idea is that if somebody's MS is not active and the medication is working well, hopefully that person wouldn't experience any relapses, and that would be the goal. Another point in relation to this is that the vast majority of people who experience relapses have relapsing remitting MS. But what we do understand is that in progressive MS, it's also possible to have relapses. So in people who have secondary progressive or primary progressive MS, relapses do occur. If somebody has a progressive form of MS, we'd still be quite aware that if there's a sudden change, and that's kind of the key thing, then it's perfectly possible they might be having a relapse. So for us, kind of as the treating team, we have to kind of think about, consider, is it a relapse or not? So if they're old symptoms of MS, they must have become worse, or else they're brand new. They must be present for at least 24 hours, at least 30 days from the last relapse, and no other explanation. I suppose this is kind of on average. People with relapsing remitting MS have about 1 relapse every 2 years, but it's very, very variable, and it depends from person to person and treatments, and there are many factors that influence this. One thing we do know is that in general, during pregnancy, women are much less likely to have a relapse, but the risk increases after the birth of the baby, and particularly in the first 6 months. Then following a relapse of MS, recovery begins and the body starts to heal itself. And it usually kind of, people will notice the first 2 or 3 months, there's an improvement in whatever the problem was, but that recovery can continue for well up to a year or even beyond, depending on the circumstance. So the next point in the talk is what happens in a relapse. So a relapse of MS, it happens when there's an acute attack of the immune system on the coating of the nerves of the brain or the spinal cord. So what you'll see here in the cartoon on the top, this is the body of the nerve, and this is the outshoot, which we call the axon. And this is coated with this substance called myelin, which is kind of like a fatty substance. And it has a number of functions. It protects the nerve, and it's involved in nourishment, and it helps the signal go smoothly down when the signal is sent. But if there's an attack, it means there's an increase in stripping of this myelin by the immune system attacking this coating. And what we think happens in a relapse is that it's if a part of the nervous system that's involved in a particular function, like walking or bladder function or sensation, then the person becomes aware of it and they notice they're having symptoms. So this is an example of a scan, an MRI scan, and many people with MS will have scans throughout the course of their treatment. So it's just to give you a sense of what we might see at the treating end. So on the top, we have a series of scans, and these are taken at 3 time points. So this is kind of the baseline. Then during the attack, there's this brand new white spot, which people would call a lesion. And then as time goes by, that kind of shrinks and gets a bit smaller. And that kind of matches what we would see with the person from a clinical perspective. Then sort of at the bottom, it's a different view of the brain, if you like. So there's nothing in this area. Then there's this acute region where the person's been given a dye through their veins. And then that kind of recedes and it leaves a sort of a black mark or a scar on the scan. So ultimately, what you're kind of seeing is nothing obvious, something acute, and then it recedes, but it does leave a bit of a mark. And that's kind of what you would, the sense you would get when you talk with someone who has MS, that while they have a relapse, they do recover. It may leave a bit of an aftermath, and it depends where in the nervous system, and it depends on the severity of the relapse. So the next kind of important question is, how do you know you're having a relapse? And this is a question we're frequently asked, and my nursing colleagues are also asked this quite often, and particularly important for people with a new diagnosis of MS, where there's a lot of uncertainty. So the key point, I suppose, is listening to your body. So kind of getting an understanding of where things are at the moment, so that you could sort of consider that to be your baseline. So whatever the way things are now, and if all else is equal, then if there's a change from that status, then you would begin to think there's something new happening. And the point is that there's a new change in neurological function. If there's ever any uncertainty, or you're kind of in doubt about is this a relapse or not, we would always recommend having a chat with your MS nurse who's really experienced and would have years of experience of meeting people with MS and treating people with MS, or your neurology team to discuss your concerns if you're unsure. And it's very common to be unsure. This isn't unusual. And the reason that this can happen is sometimes if the body's under stress, an old symptom can come to the fore, and we'll come back to that in a bit. But the key point, I suppose, is communication. One thing, I suppose, from the point of view of an MS nurse or a doctor, there really isn't a test at the moment to say this is definitely relapse. Now, I did show a scan there a moment ago, and that's from a research setting. But in terms of clinical work, there isn't a blood test or any other thing that would say definitely this is a relapse. So from our end, what we would do is we would ask the person, if they've had other relapses, does this feel like a relapse to you? And usually the things that people will tell you is that they've tiredness beyond their usual level of fatigue. They're really clear that the symptom is new. They don't have any infection. It's been going on for at least a day, and they usually haven't had a relapse for many months, or maybe even many years. And when you put all those things together, then we'd examine the person after chatting with them. And if we see something that we haven't seen before, then we'd say, look, it looks like you may be having a relapse. So it's a combination of the person having an awareness of what's going on, identifying things that are new, communicating that with the nurse, and then setting up a meeting to kind of confirm that and get the treatment going. So I suppose that's kind of what is a relapse, how do you know, and then what isn't, because I touched on that briefly. So the main thing is if your body is under stress. And stress comes in many shapes or forms. So common things in MS can be infections. So a urinary tract infection is quite a common thing. Generally, anything that increases your body temperature. So we've experienced quite high temperatures in the last couple of weeks, even in Ireland. Stress generally, say in the workplace or in the home environment, or if there's an increase in tiredness from any particular cause, say flying home from a long haul flight, or sleepless nights with a new baby, or any particular reason that tiredness or fatigue is increased. And then for women, during hormonal changes, for menstruation, menopause, and sometimes during the early stages of pregnancy, all of these fluctuations change the physiology of how the body works. And what this means is that old relapses of MS can seem very real again. And the point is that these would be symptoms that are not new to the person. They would have had them many years back, but just they seem very recent. These are things that we would often say. So kind of just the main thing that we would see that can look like a relapse is someone has an infection. The only sort of point, maybe just as an aside, is if someone has a particularly severe infection, it can trigger a relapse. So it's still important to contact, I suppose with maybe a bladder infection, the first point of call might be the GP, just to have your urine dipsticked, or maybe then if it's appropriate to start an antibiotic. But if somebody's very, very unwell and needs hospital care, it may also be possible to have a relapse. The other things I mentioned there are heat or cold, stress, tiredness, general deconditioning, or for women when they have a period. So what to do in a relapse, I suppose, is often then an important question that people would ask. So the key thing really is to contact your MS team. Even if the relapse is mild, it mightn't need treatment, and we'll come on to treatment in a moment, but the point of communicating with your team is that it lets your team know that your MS is active at this point in time. So generally, we think about MS in kind of two ways. We think of it as either being active or not active. If it's not active, we would kind of think that the treatment would seem to be working, whatever the disease-modifying drug is. But if it's active, either it means that the person hasn't started on the drug, or maybe not enough time has gone by for the drug to take full effect, or maybe it's the case that the drug isn't working as well as it should. And the purpose of communicating the relapse then would be to say, just to consider this and discuss. And as it says here, this may prompt a change in the treatment. It's very dependent on the context and for the individual. So if it's possible, what we would kind of recommend is maybe before making contact with the MS nurse or with your team, just to kind of jot down maybe a few notes. So when did the symptoms start? What was the change? And what are the symptoms? What part of your body is affected and how? So say, is it numbness in your leg or both your legs or your arm? Have the symptoms kind of stopped you from doing what you would normally do? For example, day-to-day activities, working, getting dressed, showering, etc. And then importantly, have you had any illnesses recently? So a big thing that many people with MS have been describing in the past 2 years have been if they've been infected with COVID, many people experience a severe setback in their symptoms and a real sudden increase in fatigue. So that would be an important thing to communicate. And then lastly, if there's been any change in medications, so for example, new antibiotics or new blood pressure tablets or whatever the case may be, it might be a medicine that you think isn't relevant, but you'd never know. And all of these things are important to take into account. So the next point then is how are MS relapses treated? So I suppose the first thing to say is that not every relapse needs treatment, but as discussed already, the point of a relapse is it shows that MS is active. So the underlying, even though the relapse itself mightn't need treatment if it's on the milder end, but the fact that the person's MS is active might mean that a discussion could take place to discuss the disease-modifying drug. In terms of treating the relapse then, it's usually not one thing, but a combination of different things together to treat. So the first thing that people would often think of is steroids. Steroids come in many different shapes and forms, and anybody who's experienced a relapse would understand that sometimes they're given through a drip in the hospital. There are different protocols or regimes, and this can vary from center to center and country to country. So usually it's a drug called methylprednisolone. The usual dose is 1 gram, which is quite a, it's a big dose of steroids compared to other diseases. And then how long it lasts can be for 3 days or 5 days, or anywhere in between, depending on the circumstances. What has emerged in recent years is that there's now evidence that oral steroids can work as well as through a drip. And this can depend on the person. It depends on how severe the relapse is. Some people's wish might be to stay at home for the treatment. So if it's, say, a long distance from their home to the hospital and it's tricky to get into the hospital for intravenous steroids, well then the oral medicine might be worth considering. Other people prefer coming to the hospital. And it's important to say that not every relapse needs admission into hospital. In fact, in our centre, we would often try to avoid admitting people into hospital to keep them at home, and maybe just attend as a day case if they're going for intravenous steroids. And that would be true of a number of different MS centres around the country. But it is, as I say, there's individual variability, as with all these things. So we mentioned steroids. That's kind of the medication component of the treatment. But there's more to it than that, I suppose, as is the case with many components of MS. So at the top here, I have the MS nurse. So I suppose they'd often be the first point of contact to say, as a person with MS, for you to communicate with and say, you think there's something happening, it's something new, you haven't experienced it before, it's been there more than a day, you don't have an infection, and there's nothing else going on. So what the MS nurse might do is communicate that with your team, arrange for steroids, which can be, as I say, either a tablet or through a drip, and then in tandem with that, start the rehabilitation process. So there are many different strands to rehabilitation, and with all of these things, it can vary, the availability can vary from centre to centre. So usually a key component of it is physiotherapy. And we know physiotherapy is very important throughout the course of the disease, but it can be particularly so if somebody's having a relapse, because if there's a loss of function, what you want to do is kind of retrain the body to get that back. And we know that by kind of actively using a muscle group or balance or standing or walking, it can encourage repair of that pathway if there's been a relapse affecting it. And then equally, occupational therapy has an important role to play. And again, it very much depends on where in the body was affected by the relapse, how what sort of activities of daily living have been affected, and OT are really excellent at sort of identifying practical solutions to things if there's a difficulty with a particular day-to-day function, and they often provide excellent solutions. The other component of physio and OT would be that even though they're very often hospital-based, there are excellent community physio and OT people right around the country. So again, I suppose thinking of people who live a little bit further away from the hospital, even if they're referred to physio in the hospital, it's possible to set up links with the community so that they can be reviewed by physio. And equally, it's important to say that with MS Ireland, each regional chapter would often have links with local physiotherapy groups and so on. So there are many ways to access these services, even if they're not immediately available through the hospital. For some centres, and not everywhere, there is psychology. The reason for discussing this part is that, as I mentioned earlier, people do experience cognitive relapses. And if that's the case, we know that rehabilitation isn't just a physical thing, and there can be a cognitive component to that. So for some centres who have this, this can play a role. Again, though, psychology is often, I think it's increasingly available in the community. So for some people, that's sometimes an appropriate treatment as part of their rehabilitation. The next part then really would be a follow-up appointment, and the time interval might vary depending on what's going on and the circumstances and so on. The purpose of the follow-up appointment would be usually with the nurse or with the neurology team, and it would be to discuss what happened and how the treatment went, the rehabilitation process, and then to kind of review things with the person's MS generally. So it's sort of to consider how many relapses have occurred, what medicine they're on, how did their recent scan look, and then to sort of think more broadly, do any of these things indicate that the person's MS is active or not active, or what way to go? And then there might be a discussion about disease-modifying drugs, and then trying to come to a conclusion as to whether maybe to continue on the one the person's on or to consider a change. Importantly, though, other lifestyle factors are very important to think about at this stage. So the medicines are certainly important, but they're not everything. So things that might be discussed would be levels of physical activity. So we know that people who are more active, it definitely has an effect on modulating the immune system in a very positive way. So we would try to encourage people to stay physically active. And that would be a further purpose of linking in with the physiotherapist, who'd be very good at providing sort of an appropriate exercise program or pattern. Then in terms of other components of life, trying to manage day to day and week to week in terms of having a job and home and relationships and so on, occupational therapy might give advice in that regard, and managing stress, because as discussed earlier, stress can be sometimes a trigger for relapses. There are other lifestyle things then that would be important, and really a key thing would be smoking. We know that smoking cigarettes increases the number of relapses of MS, and it increases the progression of the disease as well. So if somebody's had a relapse, it's not that we would be giving out or anything like that at all, but it's just to be aware that smoking cigarettes does change the disease course in a negative way. So it's worth considering, and worth thinking about all these lifestyle factors. So in terms of recovery from a relapse, there are different things to think about. So home life, in terms of mentioned sort of work-life balance and all of that. And I suppose it comes down to trying to have a plan or sort of a system in place to manage stress. You can see that the dad here on the cartoon is under a bit of stress himself. And it's kind of probably one of those things where it's easier said than done. And I suppose since COVID, many people are working from home, and that presents sort of sometimes it's advantage. It can provide an advantage, but it can provide challenges too in terms of childcare, managing school runs, drop-offs, all of that, and then trying to keep the sort of the show on the road in terms of running the house. So I suppose that if somebody's had a recent relapse of MS, the way things might have been possible for a period of time might change. So sort of reaching out to the sort of your supports would be important in terms of family or friends or other people who are involved, who might be able to sort of increase that support in the short term if there's something that the person was previously able to manage very well, but because of new symptoms of their MS, that might change. So kind of how to sort of structure things on a day-to-day basis. The next thing is kind of similar then in terms of work or study if somebody's in university. And work, work is something many of us would do, but it can provide, there can be times where it's particularly stressful. And similarly with college or coming up to leaving cert, or depending on the stage, education can provide similar challenges. So I suppose, again, it kind of comes back to communication. So for people in the workplace, it may be a case that in the short term, a change or a modification in sort of the working week might be necessary, whether that's maybe in the short term, stepping back for a little bit, maybe reducing to 4-day week or 3-day week, or splitting the 5 days out, or whatever arrangement is possible. And it depends from person to person, because everyone's work is different, and everyone's management and work is different. So some jobs might lend themselves to greater flexibility. But I think the thing is that for people who've had a relapse of MS, generally they would describe an increased level of fatigue, and that can be a challenge. And the fatigue is not just a physical thing, but it also can affect brain function, and people might describe a brain fog or something like that. And that's sort of a challenge in terms of trying to perform at a high level for work or study. So it's kind of a case of recognizing in yourself that just a little adjustment or a change is necessary, and then sort of taking steps. So again, in terms of a part of that communication, relaying those difficulties to your MS nurse can often be a useful thing, because they may be able to provide you with some solutions or tips or strategies. But equally, if you need letters of support, or you need somebody to communicate with your workplace or with your where you're studying, that can be useful. And it's certainly something that we would be asked for on a fairly regular basis. And it's never a problem or a difficulty to do that. So it really, the heart of it is communication, I suppose. The other part that many people sort of find an unexpected thing after a relapse of MS is feeling emotional. And it's perfectly normal to feel emotional all of the time. And some people express that differently. And some people, as we know, are more emotional than others, and some people less so. But because of what goes on in terms of the change in brain function and the change in the immune system during a relapse, and sort of a change in levels of energy and fatigue and many of these things, that can have an influence on how people feel about themselves, how they feel about their body, or how they sort of perceive themselves in the home or the family unit. And I suppose for many people, unfortunately, this can have a negative effect. So it's not uncommon at all to feel down or low, or maybe even depressed during a relapse or even after a relapse. So these are things that we would commonly see. Again, though, I suppose to stress that there is treatment available for that. And that treatment could either be with your GP locally. It could be sometimes talking about it. So setting up an appointment with a therapist can be very helpful. It sometimes requires medication, and that can be done through the hospital. So again, your neurology team or your MS nurse might be able to point you in the right direction. And then sometimes some people, even by discussing it with their nursing team or discussing it with their neurology team, might feel a degree of relief that this is a thing that many people with MS experience, and this can be a normal thing after relapse to feel a bit down or a bit low. And it generally, a bit like the physical recovery from a relapse, the emotional changes do tend to level off, and most people find that after a period of time, things do generally go back to baseline again. In line with kind of the emotional part, thinking can also be affected. So I suppose this is kind of a cartoon trying to describe brain fog. which is a thing that at baseline many people will experience. But what a relapse might do is just sort of to worsen that process. And I mentioned COVID earlier, and it is a thing that people with COVID would frequently complain of, and particularly people with long COVID. But in MS, this is something that we've recognized for many years, that it's kind of trying to think about many things quickly or process a lot of information. Just sort of getting a handle on all of that can feel a little bit different in the immediate aftermath of a relapse. A bit, again, like the emotion or the physical components, it can improve for sure, and it can take some time. Some people would find that getting treatment with the steroids can help that. Some people find linking in with psychology can be helpful. And then there are strategies sort of at home to sort of, many strategies that are now available in terms of brain training or cognitive rehabilitation. So coming towards the end, the next kind of topic I was going to cover is how to reduce the risk of relapses in the future, because I suppose we kind of described what it is, what it does, what to do, and then ideally, how would we prevent them? So there are a few things, I kind of touched on them earlier. So I guess for anybody at any stage in life, staying physically active is really important. And what the World Health Organization recommend is at least 30 minutes of activity per day. But that doesn't have to be anything sort of extraordinary. You know, going out to the garden and walking around would be physical activity, unpacking the washing machine, loading the dishwasher, doing things around the house, picking up the shopping, whatever it might be. And then if somebody has a degree of physical disability, modifying what's done. So for example, some people would do seated yoga, some people would do yoga on the floor, and it very much varies from person to person. And the key thing really is to identify what's possible and what's sort of within person's reach to do on a regular basis, rather than kind of sudden bursts or starts of hitting the gym very hard and then not doing anything for months on end. And then a key person in this can often be the physiotherapist to give a bit of guidance in terms of the sort of do's and don'ts with exercise. The next point that we're realizing more and more is important is body weight. And the reason seems to be that body fat that we all have plays an important role in the immune system. But if there's too much body fat, it can sort of rev up the immune system more than you would want. And in a disease like MS, where the immune system is attacking the nervous system, by reducing body fat, we think that that may have a positive effect. We know that for people who have an increase in body fat before their diagnosis, that can sometimes be a risk factor. And at the risk of sounding like a broken record, it's so important not to smoke. And we know that stopping smoking can, in fact, it can have the same effect as almost starting a drug for MS. So it really is so important. The reason smoking kind of came to light was many years ago. Our colleagues in rheumatology identified that people with rheumatoid arthritis, which has many similarities with MS because it's a disease of the immune system and appears to affect women more than men, does worsen for people who smoke. So they studied it in a bit of detail. And what seems to happen is when people smoke cigarettes, the particles in the cigarette go down into the lungs. And because they're foreign particles, it results in an immune attack. And all of these sort of active immune cells are then left in the bloodstream, and they can attack then the brain or the spinal cord. So by stopping smoking, you're kind of reducing the immune response, and that's really the key part of smoking. The last kind of sort of lifestyle bit then is stress, and I talked about that already. So there are many different ways in which stress manifests, and I suppose it's kind of it's individual, and it's hard to give a very definite plan to a group of people because everybody's lifestyle is different. It depends on a home situation, it depends on work, it depends on relationships and many other factors, and it's not possible to avoid it at all. We all experience it in different shapes and forms, but it's, I suppose, and the idea would be to try to develop coping mechanisms or coping strategies so that the impact of the stress doesn't have a negative effect on your health. The next kind of, so in terms of lifestyle, that will be one part. And I mentioned disease modifying drugs a couple of times during the talk. So a key person again here would be the MS nurse. And what if below are a list of various different disease modifying drugs. I'm not going to go into them in detail, but it's really the purpose of listing them, or a few of the more commonly available ones, is really to say that the number and the extent of drugs is far more than we've ever had before. So maybe 20, 25 years ago, there would have been one drug available, and now we've reached a point where there are over 12 drugs licensed for the treatment of MS. And even at this point in time today, many new drugs are in the pipeline, and we're anticipating that newer classes of drugs will become available in the coming years, and perhaps even before that, as well as new approaches to the treatment. So if there's any signs that a medicine is not doing what it should, then this would be the purpose then of the communication, to sort of go through, is it working, and what are the options? And the options are many. And I suppose similarly for somebody who has MS, and maybe for a variety of different reasons, might have been a bit reluctant to start on a medicine. If they have a relapse, then it might be an opportunity to review that and then maybe to discuss again, could there be treatment options, and might it be worth thinking about it again to see if there's something else that maybe wasn't available a few years ago that might be now, and might be a sort of an appropriate treatment choice for the person. In terms of what does disease modification mean in a practical sense? So I suppose in terms of the immune system, it's a complex system, but there are two cell types really that you will hear a lot about. And I suppose particularly in the moment in the context of COVID, we hear an awful lot about the immune system. The two main cell types are B cells, and this is just a picture of one of these fellas here. And what these guys do is they make antibodies. And as I said, when COVID hit and vaccines were released, we've heard a lot about antibodies in the media. In the terms of MS, we know that antibodies can be a bad thing because they're sort of targeting the immune system in towards the nervous system. So there are kind of then two strategies, and one strategy can be to break up these B cells. And there are a number of different medicines that can kind of break them open, if you like. But it does take a bit of time. So there's kind of a lead-in time for the medicine to take effect. The other type of cells are T cells, and there are different strategies to these cells too. So some medicines sort of block these fellas from getting into attacking the brain. Some medicines sort of reboot the immune system, if you like. So it kind of puts the brakes on these guys from reproducing, and then brand new T cells are made. And the idea of making brand new T cells would be then that they're not primed to attack the immune system. And there are a couple of different treatment strategies like that. And then some medicines have an effect on both the B and the T cells. So there are various different strategies. And kind of the trade-off with all of these strategies is the stronger you attack the immune system, then there is sort of an increase in the risk in terms of infections. But the trade-off then is trying to keep the MS inactive or in remission, if you like. So we're coming towards the end. So what I'm going to do is just to kind of recap, I suppose. The key thing, I suppose, in terms of conclusions is the importance of communication with your team. If you're having a relapse, or if you think you're having a relapse, and then just emphasize that if you are, it may indicate that your MS is active, and that would be the purpose of communication, as well as, of course, trying to get treatment in place or a treatment plan in place for the relapse. The next point would be to try to understand yourself from your own body, if the symptoms are new, or if it's an old relapse. And kind of going back to an earlier point about maybe jotting down some notes can often be very helpful in terms of what is your baseline like, what has changed, and are there any stressors on your body at the moment that might have resulted in an old symptom coming out to the fore again. And then lastly, there are many factors that can reduce the risks, and it's a combination of things rather than any one thing. So it's usually a combination of a disease-modifying drug and lifestyle that can be sort of the main way to reduce the future risk of a relapse. So that's the end of the presentation, and I'm very happy at this point to take any comments or questions that anyone might have. So I'm just going to stop sharing my screen.
And Dr. Kearney, thank you so much. That was so informative. And we do have lots of questions in, and we received a few in advance as well. So just being mindful of time, we might get moving with them. So one question in here is the correlation between times between relapses a predictor of future disability?
I suppose it's, yeah, it is a factor, all right. I think if you were to say that somebody was having very frequent relapses, it would, the overall impression you'd have is their MS is very active. And what we know is that the less relapses people are having, the better the long-term prognosis. So there would seem to be a link. And I guess this was looked into a study in London many years back. They looked at people who had a first presentation of MS, and they tracked them every year for the first 5 years very closely with a scan and a clinical assessment. And then what they did was they called the people back 20 years later to see what their very long-term outcome was. And there did seem to be quite a link between the activity on the scan and the activity the person had and what happened 20 years out. So that really is why a lot of the emphasis nowadays is put on trying to diagnose MS early, and once the diagnosis is secure, to discuss starting on a form of treatment as early as is possible.
Thank you. And there was another question then regarding, do more frequent relapses suggest that somebody is moving from a relapse and remitting phase of the condition to a more progressive form of MS?
Not necessarily. So it's possible to have relapses in relapsing remitting MS. It's possible to have relapses in progressive MS. But overall, the change from relapsing remitting to progressive is sort of a very slow change or deterioration. And the thing that people would usually notice that marks that change is a change in their walking. There may be other, in fact, there usually are other components to it. But it's kind of walking distance or walking speed that over months or even years would change rather than an acute sudden change. So very frequent relapses would typically more point towards their MS being active overall rather than a change in category.
Thank you. And is there a role for the use of estrogen or other hormone therapies in helping with MS symptoms and relapses, since relapses lessen during pregnancy?
Yeah, absolutely. That's a very important point. So there have been studies in the US looking at a combination of a drug called Copaxone, which is an injection, and then giving women supplemental estrogen. And then more recently, there's been a lot of research, interest, and work in treating menopausal symptoms, because we know that women going through menopause can have a change in their MS. And now this is probably a change that we would recommend people to attend their GP, and if it's appropriate, to consider hormonal replacement therapy. We're not really at a stage where we would necessarily prescribe hormones in terms of an immediate relapse, But if there is anything else medical going on in terms of a reason for somebody's hormone levels to change, so for example, with another endocrine problem, it will be very important to look into those other things and make sure that each component of the person's health is under review and is treated.
Great, thank you. So there's one message in here from somebody who said that they have had a relapse this year after 11 years, and it started with a dose of shingles. And would it be a good idea to get vaccination against shingles into the future? And you might just comment generally on the use of vaccinations then for the flu maybe and things like that as well.
Yeah, absolutely. So I suppose the shingles can be severe, and there is now the Shingrix vaccine, which has been shown to be very effective. So I suppose in that case that you know there's a very particular scenario, but we would recognize that when an infection is very severe, it could trigger a relapse for sure, even if somebody's been very stable for many years. I suppose then more broadly, vaccines are really important in terms of public health generally and at an individual level. And we would always strongly recommend that people get vaccinated. So I suppose the two things that would be sort of immediate would be flu and then COVID as well. So to make sure that each winter or spring season to get the flu vaccine, and then as the next sort of round of boosters for COVID are coming around, that if you fall into a category where that's applies to you, we would strongly suggest that people do get it. This has been studied many times over many years, and there's no evidence to show that a vaccine would increase the risk of a relapse or change MS. So we would be quite certain that people with MS should definitely get vaccinated, and there are many guidelines from national and international MS groups sort of outlining what are the vaccines that you might need, and then with particular medicines there might be slight changes in that, but overall it's so important.
Great, thank you. And would an increase in fatigue be considered a relapse?
It's difficult to know. I suppose some people's relapse can consist of just one symptom, or some people's relapse can be a combination. So for example, if the fatigue is accompanied by a change in thinking, or somebody feels their cognition has taken a dip from what their usual baseline is, then it certainly could be a relapse. And I suppose it depends on the overall picture in terms of how the person is and how the person feels.
Apologies. On that note, how could somebody identify if they were having a cognitive relapse?
Yeah, it is a challenging thing. It's not easy. I think it comes back to kind of listening to your body and understanding what is your baseline. So kind of a sort of an assessment or a scan, if you like, of yourself internally. Do you know, how do I function day to day? What are the tasks I can do that are within my reach? What are the things that I enjoy doing, like reading the newspaper, listening to the news, whatever it may be. So sort of you have a feel for broadly what is your level of cognitive function at baseline. And then if there's a sudden change in one of those parts, so for example, if doing your work tasks is more challenging than usual, or keeping up to speed with lectures in college, or maybe finding reading a book is just beyond you at this point, and this has been a sudden change, and you're sure that you don't have an infection and that change is lasting more than a day, then that could be a cognitive relapse. There are kind of more formal tests that are available. It's something that's often discussed a lot, and there are different sort of shapes and forms these tests can take place in. So that would be sort of the more formal way of kind of getting to it. But again, I suppose if that were to be the case and there was uncertainty, the key point would be to communicate, to link in with your MS nurse, your MS team, so that they would say maybe be able to review you either on the telephone or maybe in person.
Thank you. And there's a question there as well. Is it possible not to get any relapse, or that it would be so mild that you wouldn't notice? And by not taking any treatment, are you making your symptoms worse?
So I suppose what we think about with relapses is that that's where the immune system has attacked a nerve that does a particular function that you're now aware of. So it's possible to have activity of MS in the background that the person mightn't be aware of themselves. And that sort of feeds into why do we do a scan each year for somebody with MS. So the scan can indicate activity, but the person themselves mightn't appreciate that that has yet sort of caused a change. So what we're kind of doing in clinic is sort of a combination of understanding from the person what has been their course or how have things gone for them, and then also looking at their scan and saying, are there changes on the scan that indicates new activity? And it's a combination of the two, because the person, as this person has described, could feel very well. The relapses might be mild, but the fact that they're there at all would probably suggest that the MS to some degree is active. And then I suppose that would feed into the discussion about treatment, which would be an important discussion to have with the neurology team.
Thank you. I'm just conscious of time, Dr. Kearney, and we're just 3 minutes left in this. I'm wondering if we might be able to go over by a couple of minutes, just
no problem at all.
Through some of these questions. Brilliant.
Sure.
So just, is there any evidence that vaping would have a similar effect to smoking cigarettes on MS, considering the nicotine levels are lower or absent in vape?
We don't have evidence to say that for sure. We've very clear evidence on smoking sort of normal cigarettes, if you like, or I suppose tobacco cigarettes. We don't know with electronic cigarettes. Generally, our sense, though, is that it probably does have an effect on the disease. The reason that we think that is because you're inhaling something foreign, something that the body is not making. And anything foreign that goes into the body generally provokes a response of the immune system. So if you think of a common scenario, like if you put a splinter in your finger, you'll see redness and swelling, and it kind of looks a bit nasty. And that's because the immune system is attacking the foreign piece of wood. So then if you think about an electronic cigarette, it does have fumes that come from chemicals. Those chemicals are foreign to the body. So it wouldn't be a surprise in the future if we have evidence that that is changing the immune system. So we would still advise people, if it's possible for them, to stop smoking altogether, including electronic cigarettes.
Thank you. And do supplements like vitamin B12, vitamin D, and vitamin K help people living with MS?
So I suppose the main kind of supplements that we'd often be asked about would be vitamin D. And the reason that that kind of comes up many times is we know that having a low level of vitamin D earlier on in life can be a risk factor for developing MS. But what we don't have definite evidence for is that if you put that vitamin D back into the system, does it change the MS itself? What we think is of importance, though, is that many people with MS later in life, in their 70s or 80s, can suffer from thinning of their bones, and vitamin D does play a role in bone health. So we would replace it, and we would prescribe replacement vitamin D if somebody is low on it. Similarly, B12, which you mentioned there, is very important, and it's a very common thing that people would have a low level of B12 for many different reasons, and that would be a really important vitamin to replace. The difference, I suppose, is that B12 often has to be given as an injection at the beginning, or maybe on an ongoing basis injection. So it might need to be given by the nurse in your GP practice, but it's often picked up on a blood test. So that would be part of a general health screen, maybe.
Thank you. We have a comment in there about the hospital that has no MS nurse, no OT, no psychologist, no physio, and is just about to lose their sole consultant and neurology consultant. I'm actually going to suggest that this person would email Alison. Alison here is the Advocacy and Research Officer with MS Ireland. Alison, I might just ask you to send your email to that person in chat, and maybe they can pick up that issue with you for comment, just in the interest of time. Can you predict what your relapses will look like in the future based off of past relapses?
Unfortunately not is the answer. Because sort of what you would think of as a relapse is the immune system attacking a nerve that hasn't been attacked before. So it has to be something that's new, and where that might be in the body and how that might sort of show itself, if you like, is very different from person to person. I think to come back to it though, again, the key point would be to have an understanding of where your baseline is, what is going on in your body right now. And then if something does change, to sort of be able to pick up on that as early as you can, and then to communicate that, even if you're uncertain or unsure.
Great, thank you. I'm just going to take 2 more questions just in the interest of time, so apologies to those we didn't get to. Dr. Kearney, is an MRI activity new lesion in the absence of symptoms considered a relapse?
We wouldn't call it a relapse, no. What we would say is that it's activity of the MS, and I suppose it's something which you kind of have to look at in the context of how the person's doing overall, how the medicine they're on at this point in time is going for them, how their other medical conditions are, and then how many new changes on the scan there are. So one small new change could happen, but if there are many, say 3 or 4 big changes on the scan, then that might prompt a change in the treatment. So there would be a discussion to be had, and that certainly would be reviewed in detail.
Thank you. And then the final question, can relapses be left untreated? Will they pass by themselves?
Yes. So if you don't, say, for example, you feel that you would manage without steroids, or you sort of take on the rehabilitation yourself by walking or swimming or whatever the case may be, the body will heal itself. And we know that in MS, when myelin is lost, it can regrow. It varies. It depends on the site of where it was attacked, and it depends how long the nerve is. And that's why the recovery process can differ from person to person. So if it's a relapse that the person might feel is on the milder end compared to what they've had in the past, then the recovery is usually a bit shorter. And if it's more severe, then the recovery is longer. Really, ultimately, what steroids will do is reduce the sort of swelling and inflammation in the short term. So what they'll do is speed up the recovery, but not change the overall outcome. So even as that person says, if you were to do nothing at all, then the body certainly has the capacity to heal itself. But I think it would again be important to emphasize that even if you feel you don't want to seek treatment, it would be good to just let your treating team know that this has happened, so that can be fed into your next consultation.
Brilliant, thank you. And Dr. Kearney, just to say there, we have some comments in already from people to say that they had enjoyed the session, and thank you very much for all of the information. So thank you so much for your presentation and for answering so many questions. We really do appreciate you taking the time to do this for us.
Not at all, and thanks again for the invitation to talk, and I hope everybody took something away. So I'm very happy to take part. Thank you.
Well, thank you. Just as a reminder to everybody, this session has been recorded and we will be popping it onto our website in the coming days. Thank you, everybody. Goodbye.
Thank you all.
Bye-bye.